Welcome to another episode of Boomer Health at Home. My name is Megan Gervin, Assistant Director of Nursing for Ameris Staff Nursing Services. Today, we have an expert in interventional radiology, Dr. Jeffrey Isaacson. Welcome to the show, Dr. Isaacson.
Thank you, and thanks for having me, Megan.
So today we'd like to discuss a lot of options to patients that they just don't really know about. There are alternatives to surgeries that you can do. But before we get into all of that, we want to talk a little bit about you. So Jeff, where did you grow up?
Of course. So yeah, I grew up in a small beach town on the shoreline of Connecticut, east of New Haven, called Westbrook, Connecticut, and has a lot of shoreline charm, and it's one of those towns where the population triples during the summer, and everyone trying to get their New England summer in, and one of those places that you learn to appreciate more and more as you go through life. And so it was a great start, great academics, and just very lucky to have grown up there.
Very nice. So did you know that you always wanted to go into medicine?
So I think I was always very interested in athletics and how the body worked, and kind of coming through life, I pictured myself as an orthopedic surgeon originally, and once I got into medical school and heard about radiology and interventional radiology, I knew there was nothing else that I could do, and that this was where my career was going.
Oh, that's very nice. So where did you do your training?
So I went to medical school at Ross University, where I met my wife, Leah, who's a practicing rheumatologist in West Palm Beach. And then for my medical internship, I was at Cleveland Clinic in Weston, Florida. I went back home to Connecticut to do my radiology residency because we're all trained diagnostic radiologists. And I went to Hartford Hospital for that, a big level 1 trauma center with lots of high-tech procedures and operations going on. And then I finished up my training in specialized fellowship in interventional radiology at MD Anderson Cancer Center in Houston, Texas. So a very, very strong cancer center where I got some excellent experience. So very lucky throughout my training just to be at some great programs.
And I heard you did some rotations in Michigan.
I did. So at St. Joseph Mercy in Oakland. So I did some rotations there. My wife is from Michigan, and my in-laws still live there. Brother and sister-in-law are in Grand Rapids. I lived in Bloomfield Hills for over a year. And so, Michigan in general and Oakland County really has a special place to me, and special place in my heart.
So where do you practice now?
So I practice in Martin County, Florida now. We decided to skip out on the winters and head down to Florida. So that's where we are now.
No more seasonal beach season, more all the time beach season.
Exactly. We get plenty of visitors from up in Michigan and Connecticut all throughout the winter. So
I'm sure.
Guys.
Snowbirds go a-flocking.
Absolutely.
So we'll start out very general. What does an interventional radiologist do?
Yeah, so this is a really good question to start. And I'm just going to speak in broad strokes here, but my best way to describe what an interventional radiologist do is that we do a wide array of image-guided, minimally invasive procedures. So we're using tiny incisions in the skin to gain access to the blood vessels, whether that's the arteries, the veins, the lymphatic system, or directly through the skin into the chest or abdomen or different organs to perform a various number of procedures.
So this is on top of being a doctor, correct? So you
Absolutely.
go for like a fellowship to become an IR doctor.
Absolutely. So you go to medical school and you get some medical or surgical training, and then you're fully trained as a radiologist also before you go into IR. So I think it's a big benefit to us to have that medical knowledge just heading in.
So I think a lot of people too, when they think of radiology, they think of maybe like an X-ray or a CAT scan. They don't really think of interventional radiology. They don't really know what that is unless maybe they went in for like a PICC line or something like that, but they really don't know the scope of everything that you guys can do and how much it's evolving.
Yeah, absolutely. And interventional radiology to me is the best kept secret in medicine. And I think that's almost funny to say if you work in a hospital setting, because you realize how much the hospital services do lean on interventional radiology, and we're frequently involved in patient care, no matter what the illness that brought them to the hospital. in terms of the field in general, we're a relatively young field, 50 to 60 years old, and that the first IR procedure was really performed in 1964. Charles Dotter actually dilated a blood vessel, and was able to kind of create the field. And first time the term was used wasn't until 1967. So relatively young. And certainly evolving. IR is becoming more and more clinically based, kind of breaking off a bit from diagnostic radiology, and we actually have our own specialized residencies at this point in time. And I think it's essential to just continuing the development of the field, really making it more clinically based and taking ownership of our patients. So there's constantly research going on, whether that's in oncology is a big field where there's a lot of research and different cancer treatments, managing all sorts of different disorders. And even procedures that we've been doing a long time, we're starting to realize they actually can have a mortality benefit and keep people alive and doing well longer. An example of that would be kyphoplasty, or kind of where we fix vertebral compression fractures. So it really is a constantly evolving field. We're constantly raising awareness, whether that's with patients, with physicians, but it is a rapidly evolving field of medicine.
So when you're saying like kyphoplasty and stuff, those things used to be more considered surgery. You would go to the OR for it. So is what interventional radiology does, is that more of a procedure? Is it considered surgery? Are surgeons and you like competing for patients? What's kind of the layout there?
No, that's a great question. So it's hard to put it in a bucket with how much the procedures vary. However, I guess the best example I could use is on a malpractice insurance application. They consider it minimally invasive surgery. So I think that is a good way to characterize it.
Perfect. So do you ever work with surgeons and kind of come up with a plan for patients instead of them going, like you're saying, minimally invasive? It's way better than having them, chop sternum to, so,
Absolutely.
doing something minimally. Can you work with other doctors and kind of come up with a plan?
Absolutely. So it's very important that we're collaborating with all the doctors and surgeons. There are certain procedures in which we'll overlap and kind of treat the same conditions or do the same procedures. However, there certainly is competition out there because of that. But we realize, as a field and as medicine, that we just need to get the patients to the best place for them to receive the best care. And that's ultimately the goal. And my experience so far is that the different specialties and surgeons really, we work well together. And neither of us would really survive without one another. And so it's important to always keep that in mind. So,
Very
patients
true.
first.
So you had talked about mortality benefits. I mean, minimally invasive has a lot of other perks to it. I mean, I know it reduces cost, but what are some other perks from doing?
Absolutely. So I think reduced cost is a huge thing as we're kind of in this era in 2022 where we realize our healthcare spending is so large. We could reduce hospital times, reduce procedure time. We talked about the mortality benefit, cost, decrease pain for patients, not having big surgical incisions, but instead being treated, through an artery or through a very small puncture in the skin. So there's tremendous benefits to minimally invasive procedures, and it really is the future of medicine and surgery, in my opinion.
I think too, with the Affordable Care Act, there was a huge push towards what's called the quadruple aim, and all of those things tie into it to where the government, spending for healthcare, they really want to see that we're reducing costs, that the quality of care is better. So interventional radiology is really pushing towards that and, making leaps and bounds towards that to help with the spending. So that's wonderful. So what types of patients do you commonly see in the IR room?
So this is another great question. This is one of the things I really loved about interventional radiology was that we're involved in just about no every organ system. We are involved, and we're involved with every single type of specialist we work along with. So just some examples of some patients and how we might be involved in their care. Kind of to start off, based off my oncology training at MD Anderson, if you are a patient who has cancer, interventional radiology is likely to be very involved throughout your care. We may start by doing a biopsy to help diagnose or really to diagnose and characterize a tumor. We would be involved in putting your port in and removing it when you're done with treatment, as well as many minimally invasive cancer therapies that we have, whether that's kind of going in the arteries and blocking up blood vessels to tumor with chemotherapy beads, bland beads, radiation beads, whether we're putting probes through the skin and actually burning tumors or freezing tumors to death. That's something that we do commonly, and often with equal efficacy to surgery. If you're kind of continuing down that line, any complications that arise from cancer, we very well will be involved in, including blocked kidneys, blocked liver ducts, ascites, where there's fluid in the belly or fluid around the chest. We're kind of head to toe involved in these patients' care. Another kind of group of patients that we'd be involved in could be patients with diabetes or smokers or people with chronic renal insufficiency, where we could use little balloons and stents and even drug delivery to open up blocked blood vessels to the lower extremity, saving people's limbs and saving lives even. On the venous side, if people have varicose veins, problems with inferior vena cava filters, chronic venous insufficiency, these sorts of things, interventional radiologists could certainly help you out and help change your life. Some other examples that I kind of had written down here were patients with liver cirrhosis. We're involved in helping getting these patients to transplant, whether that's procedures that help bypass the blocked blood flow to the liver called TIPS, or whether this is treating hepatocellular carcinomas or cancers that arise in order to allow someone to survive and get to transplant and do great afterwards. And then kind of just running down, we touched on kyphoplasty in terms of sex-oriented women with uterine fibroids that are causing symptoms of urinary issues or bowel issues or bleeding. We provide uterine artery embolization, where we go in the artery and plug up vessels and actually can treat fibroids that way without the need for surgery. On the male side, there are procedures for BPH, which is a very, very common condition where men have urinary issues due to growth of the prostate. And we do have a procedure that can be performed outpatient to treat this very effectively. So, this is all without even talking about hospital patients so much that might come in with a pulmonary embolism that needs to be treated, or deep vein thrombosis that needs to be treated, and even stroke. Some IRs will treat stroke, and we have these catheters that are able to suck out clot or dissolve clot, and so these are just some very brush stroke examples of what interventional radiology can do, and kind of how we're involved in the treatment of so many patients.
I think too, coming from a trauma ICU background, when I was bringing patients to you guys, it was when someone was not doing so hot or they started bleeding out somewhere internally, and you guys were able to go in and, instead of opening them up for a major surgery, which put extreme stress on the body, you guys were able to stop the bleeding without having to open them up. So
Absolutely, and that's something I didn't touch on. Bleeding is a huge thing with interventional radiology. Whether that's trauma, we work very closely with the trauma surgeons. You may have bleeding from an organ or from a blood vessel in the pelvis, or anywhere in the body, and we're able to kind of go in quickly and occlude those blood vessels, and you see great results. I guess along the lines of bleeding, also patients that come in with diverticulosis, you hear about, and gastrointestinal bleeding, we're often involved in the care there too, in getting this bleeding stopped. So definitely life-saving bleeding type procedures are a mainstay in interventional radiology.
very much so. And like you were saying, it's a well-kept secret. A lot of people, they assume that they went to the OR for it. They're not in a condition to remember where they went to. But what's like a typical procedure time? You're talking about there's a huge span of procedures that you're talking about, but about how long do people typically have to stay in an IR suite?
Absolutely. So for certain simple procedures, this may be a matter of minutes from the time that we start, whether we're talking a biopsy or maybe a line placement like you were talking about. And, that can last 5 minutes or so, maybe a little bit more, up to a half hour. We have many procedures that might go 3, 4, or even more hours. I've certainly been a part of some large vascular or oncology cases where we're in there for 6 or 7 hours. And so, you'll have an idea sort of before you go into a procedure. And that's something that we would discuss. And it's certainly a concern of ours. We want to keep procedure time down. But it is something that we generally can gauge and give you some sort of an idea before the case.
So for patients that are not in ICU and are not intubated and on sedation, do patients typically get what I call the woohoo drugs, the twilight drugs, to where they just don't remember stuff, but they're somewhat awake, or do they get more of a general anesthesia? Is there an anesthesiologist in the room? Is it similar to an
Absolutely,
OR
you
in
brought
that
up a really
way, or?
good point. Oftentimes, these patients are quite sick, and they may be intubated, and in that case, the anesthesia is sort of already taken care of, and we'll have a respiratory therapist or an anesthesiologist in the room during the case. The vast majority of IR cases will be performed with moderate sedation or less, and what that means is that you can still protect your airway, you can interact with the IR doctor. Oftentimes, we'll need you to follow instructions during the procedure. We may do it with just anxiolysis, which is just a Versed or a benzodiazepine like Xanax in the IV, or we may do it with just local anesthesia alone. If the cases are a little more complicated, the patient's in a lot of pain, um, other sorts of issues, comorbidities, we may get anesthesia involved and give the propofol, or that's kind of the most famous twilight anesthesia will give, and that's called monitored anesthesia care, and that's sort of like what you would get for a colonoscopy. And so it does vary. However, the vast majority of my cases, I would say, are done without anesthesia assistance.
So it's even better because people that, like you're saying, have comorbidities, they might not be able to tolerate a large surgery. They might not be able to go under anesthesia or be intubated and be able to come off of a ventilator. So this could be another avenue that they could take to where, they used to not have any options before except, a basic medical treatment or some medications.
Yeah, absolutely, and that's kind of where it branches from is and where we're developing from is oftentimes the procedures are coming in as these are non-surgical candidates, and that's the reason we get the procedure. And now we're shifting towards, wow, well, these procedures actually work. They work very well, and oftentimes as well or better than surgery. And so that's where we're sort of coming into the limelight and really getting more attention, and we should be seeing a lot of these patients right off the get-go, so we can help them in the best way possible.
So in terms of these patients, do they go see their primary care physician first, or maybe like you're talking about cancer, they'd see their cancer doctors and then maybe they get a referral to you guys? Do you have to have a referral to come see an IR doctor?
Absolutely. So generally, you will have a referral to see an IR doctor, whether that's inpatient or outpatient, and they come from all sorts of different doctors. So your primary care doctor's job would be sort of to identify the disease process and refer to interventional radiology. We also get referrals from nephrologists and cardiologists and pulmonologists and every ologist that there is. And so typically you get a referral. Certain types of procedures, you may not be required to have one especially in the outpatient setting.
Very nice. So you're talking about outpatient setting. Do people have to spend the night after an IR procedure at all, or is it if there's a complication, or when do you see them having to stay in the hospital?
Yeah, so the majority of patients that are not already in the hospital can go home after an IR procedure. We may tell you, hey, if this is something where you may have some pain after the procedure, or we may need to monitor you for bleeding and other complications that could develop, maybe you should pack an overnight bag when you come in, and just be prepared just in case we have you stay overnight. So oftentimes it'd be pain control monitoring overnight, generally just one night after a procedure. But there are people that come in all the time, even with those compression fractures and they can't walk. I could treat them and I can send them out the same day. And so we really are able to minimize hospitalization times. In the outpatient setting, there are office-based labs or ambulatory surgical centers where there's absolutely no plan of sending you to the hospital after your IR procedure. And that's becoming more and more prevalent throughout the country.
Yes, I know a lot of places are popping up around us that, and people just, they didn't understand what they were, right? Like we're talking, it's a well-kept secret. So, what type, like when you go into, we talk radiology, what types of tools, what are you using during the procedure?
So, I think starting off, the most important help that we have during our procedures are staff. So we always have nurses and technicians for moderate sedation. The nurses administering the sedation and communicating with me. If I can't always have my eye on the vital signs, they're kind of my second set of eyes and ears. The technicians helping me with equipment, getting equipment, and just making the case go smoothly. Everyone in the background in the hospital or outpatient setting that kind of is necessary to run a department is also a big part. And then we get into kind of the tools we use, which obviously imaging is a big part. And then, we work with catheters and guide wires while we're working in the blood vessels. We have multiple special tools such as stents and balloons and glue and embolization particles, ablation machines where we're able to, like I mentioned before, kind of put a probe through the skin, very, very small, and actually burn tumors or freeze nerves, working cannulas that we use just to kind of access bones and work through. So we have a gigantic tool belt. And that was one of the fun things, going into the specialty for me. I've always really enjoyed my hands and having the right tool for the job. So, we really get creative and we have a lot of tools at our disposal.
I know too, as a nurse walking into an IR suite the first time, it was like the entire back wall was a supply cabinet, like a see-through supply cabinet. I'm like, whoa, okay.
It's a big
There's a lot of
production.
stuff in
You
here.
don't know exactly what you're going to get into until you're there. So you need to be prepared for everything. So it's
Yeah.
quite an impressive.
I think too, a lot of people hear radiology, they get a little bit nervous, they think about the X-ray exposure, but they're also forgetting too, because they don't know in the OR that that stuff is going on. They're not awake for it.
Absolutely.
So how important is it to reduce, the amount of exposure to radiology that
Yeah,
radiation?
absolutely. So radiation exposures, it's a big deal. We really pay close attention to it. As radiologists, and interventional radiologists, we really have a great knowledge of reducing radiation, whether that's keeping the working field as small as possible, rotating the X-ray machine that we have to spread the dose out. They say ALARA, or as low as reasonably achievable, and that's the principle that we go to. So for most IR procedures using X-rays, fluoroscopy, CAT scan, the radiation dose is not a large concern because we are able to keep it small. It becomes more at play when you're dealing with pediatric patients or very young patients that have a wider period of time for the radiation to affect them. So we keep it as low as possible. Ultrasound, MRI actually don't use radiation at all. And so that's a great technique is I always try to use as much ultrasound as possible during a case.
Perfect. And I know too, my mom's actually, she grew up as an X-ray tech and now runs X-ray in a hospital. But going in as a kid, I always thought it was cool that they had their lead shields and their little, patches. But then I found out later the patches actually keep you guys safe to make sure you're not getting too much. So there's a lot that comes into play in keeping you guys as safe as well. Correct?
Absolutely. So we're constantly monitoring dose to ourselves and to our patients. We report dose with any report of any procedure we use that uses radiation, and so that would be available. Like I said, just trying to minimize it and use as little as possible. Our lead and ergonomics are very important as well because we want to do this for more than a couple years, and so you really
Yeah.
have to focus on posture and technique. So very, very important.
Perfect. Can you share with us one of your best outcomes? What's your greatest story that you've had in the IR?
Yeah, so obviously there's been some great traumas and I mean they're not great, but the result is great from trauma or gastrointestinal bleeding, where you see someone's vital signs, they go from very unstable and just on the brink of cardiac arrest and right on the table, you stop the bleeding, and you just see the heart rate come down, the blood pressure go up, and that's not an uncommon occurrence. Just circling back to kyphoplasty, this is one of my favorite things to do, as you could tell, because of the mortality benefit and the immediate results. I had a patient not long ago who came in from home with 10 out of 10 pain. They couldn't walk, they couldn't roll in bed, had a very, very, very difficult time getting to the hospital, but they were refusing to come in as a patient because of the COVID epidemic. So I was able to treat this patient as an outpatient, stand them up 1 hour after the procedure. They were walking to the bathroom within an hour and a half, and actually described having 0 to 1 out of 10 pain. And so, that person's going to be able to get directly back on their feet. They're going to be able to work with physical therapy. They're not going to be at risk for complications like pneumonia that can develop, or blood clots in the legs when you're off your feet for that long. And just seeing the smile on their face, that always sticks with you. And so I'm blessed to be in this field, and you just have some wonderful results.
I can speak to that too. I was a nurse aide when kyphoplasty first came out, and we had a little, 100-year-old lady, and you're right, the smile on her face when she stood up out of bed and didn't have pain and could stand up and actually walk herself to the bathroom. She was so proud and so happy. She wasn't dependent on anybody anymore. So it just spoke volumes, the huge smile that came on her face. So
It
it's
really is.
absolutely wonderful.
Yeah, and you can imagine she probably wouldn't do very well, laying in a hospital bed for weeks, or, and obviously the most important thing is the patient, but you talk about cost also. And
Yeah.
these patients are not admitted to the hospital. They're not on all the pain medications. They don't require the Percocet, the morphine, the Dilaudid, and all these big, big pain medications that can really cause an issue. Imagine, like, from even just constipation alone. It really, really makes a big impact.
I think too, the immobility, like you're talking about being in bed. I mean, the atrophy that you get just from 12 hours of laying in a bed. I mean, we do our best as nurses to do range of motion and get you moving, and you're still not putting weight on your muscles. You're not, using them. So you are going to lose it. You don't use it.
Oh, absolutely. It's so
So,
true. And I tell patients, every day you're spending in a hospital bed, you're losing about 2 days of conditioning. And so it'll take you 2 days, really, at least, to get that strength back. And so, very, very important to get people treated and kind of get them moving.
and our company does home physical and occupational therapy. So not to talk us out of business, because we are there to, rehab you afterwards of those big procedures. But it is a wonderful thing what IR doctors are doing. So how can people find the right IR doctor? Are there websites they can go to look up, you guys in the area, or how do they find one of you guys?
Absolutely. So I think one big thing is obviously word of mouth. If you have a doctor or a family member who's seen an interventional radiology doctor, then that's a good place to start. I think you could easily look online, and we're a small enough field where if you Google interventional radiologist near me, you are going to find some good IRs within that list. Reading Google reviews and whatnot, you have to take some of them with a grain of salt, and just look at them with a queer eye, and make sure you're getting the information out of them that you really want. Um, but I think those are some good ways. A lot of times, especially if you're in the outpatient setting, you'll have a chance to meet the interventionalist before your procedure, and that's really a great opportunity to ask them questions, see if there's a comfort level with them, and just sort of feel them out.
Like you're saying, the Google reviews, someone else may have had a different procedure than what you're having. So if they say that they had extreme pain, it might be different completely than what you're going to be having done. So it's always good to kind of keep that in mind when you're looking through the reviews. So is there anything else you'd like to share with us today?
So, I just wanted to thank you for having me on. And I mean, it's been a pleasure. And I really just want to spread the awareness of interventional radiology and all the great things that we can offer to patients. We're constantly educating not only patients, but physicians. And there are several times and opportunities for patients to really be their self advocate and ask their doctor, hey, I have these fibroids, they're giving me a hard time. I have these problems with my prostate, and I'm only getting recommended surgery. Maybe I should see an interventional radiologist in consultation. And so I'd like to help to just bridge the gap between the patients that could really benefit from these minimally invasive procedures and just kind of continue the development of the IR field and raise awareness. So
I like
thank you.
you're saying it is raising awareness. A lot of the doctors may have come through school when IR wasn't such a big thing. It wasn't a huge field. You guys weren't as able, to do as many procedures as you are now. So
Absolutely. And the data just keeps evolving. And for the most part, it just keeps offering stronger and stronger support for minimally invasive procedures with interventional radiology.
perfect. Well, thank you so much for joining us today, Dr. Isaacson. Thank you for joining us for another episode of Boomer Health at Home. If you have any questions, you can always call Ameris Staff Nursing at 248-288-2270 and talk to one of us lovely nurses. Thank you and have a wonderful day.
Thanks so much, Megan. Take care.